Well, good evening, everyone. Welcome. This is a very special edition of our series, Conversations about Ethics. I'm Ruth Berggren, Director of the Center for Medical Humanities and Ethics. With just a week to go before Thanksgiving, we've reached a very grim milestone in our country with 250,000 deaths. 250,000 lives lost. And healthcare systems across our nation have faced surges of cases, shortages of protective equipment, and the anxiety of so many unknowns. Here in the United States, a week before Thanksgiving, we're seeing an average of 2 new cases per second and a death every minute. At the same time, we have witnessed San Antonio's resilience and strong sense of community identity, and we really have come together to protect our own. And we do have something to be thankful for this week, and that is the opportunity to look ahead to preventive COVID-19 vaccines. Earlier this week, UT Health President William Henrich convened a 30-member working group to guide our Health Science Center towards an ethical and timely rollout of the vaccines that we understand will be in our hands at the beginning of next month. Earlier today, a panel of community leaders shared best practices they have developed in mental health, healthcare, education, and the faith community. This evening, we bring together another distinguished panel of experts to discuss ethical challenges inherent in the rapid development and widespread distribution of these very necessary COVID-19 vaccines. Today's events represent the 25th Conversations about Ethics, a series that explores ethical dilemmas that influence healthcare throughout the life cycle. I do need to review some housekeeping details, some of which you have been viewing on the slides. While this is our third conversation of 2020, our series is usually presented twice a year by the Ecumenical Center and the Center for Medical Humanities and Ethics at UT Health Science Center, with generous support from Methodist Healthcare Ministries of South Texas. We thank all of our partners for their contributions to our community and to this event. Our presenters this evening and the planning committee have no relevant financial relationships with any commercial interests related to this activity. Those seeking continuing medical education for physicians can claim their credit before midnight using event call-in. Call 210-888-8298 or use the app to enter event ID 324202, as shown in the slide. Instructions were emailed to you today. If you need assistance, always email us at humanities@uthscsa.edu, and the inbox is being monitored throughout tonight's event. Those seeking continuing education credit for social workers and counselors received an email with a survey earlier today. Please complete the survey and your CEUs will be sent to you in several days. If you did not receive the survey, please notify humanities@uthscsa.edu. I'm seeing some people in the chat worried about hearing. Dr. Patterson, can you hear me?
Yes, I can. You're good.
All right, I'm going to continue. I'm going to introduce you to our panelists this evening. They are a very distinguished group of people, and I'm going to keep their bios shorter than I wish I was doing in order to preserve their presentation time. I'm going to start with Dr. Tom Patterson. Dr. Patterson is a professor of medicine at UT Health San Antonio. He is the chief of the Division of Infectious Diseases and vice chair for faculty development in our Department of Medicine. He also directs the San Antonio Center for Medical Mycology. Dr. Patterson's clinical and research interests focus on diagnosis and treatment of fungal diseases, especially in immunocompromised hosts. His scholarly publications have been cited more than 41,000 times in the medical literature. During the pandemic, he has led the Division of Infectious Diseases efforts in clinical management of COVID-19. He is also principal investigator for the adaptive COVID-19 treatment trial conducted at University Hospital and supported by the National Institutes of Health to develop safe and effective therapies. Next, we have Dr. Matt McCarthy, whom some of you have met at previous presentations. Dr. McCarthy is an associate professor of medicine at Weill Cornell and a staff hospitalist at New York Presbyterian Hospital, where he serves on the ethics committee. He has also authored 3 national best-selling books, including Superbugs, The Race to Stop an Epidemic. He was just presenting that to us earlier this year before COVID hit. It's really hard to believe. Dr. McCarthy has been caring for critically ill COVID-19 patients since the start of the pandemic, focusing his research efforts on finding successful life-saving treatments. He was the first COVID-19 attending physician at New York Presbyterian and has helped develop best practices and clinical protocols for frontline clinicians. Dr. Wari Allison holds both an MD and a PhD in public health. She is an assistant professor of infectious diseases at UT Health San Antonio, and she directs both the ECHO and South Central AIDS Education Training Center programs. She is medical director at the San Antonio AIDS Foundation. Dr. Allison's work focuses on improving healthcare access for underserved, marginalized populations by combating disease-specific racial, cultural, gender-based, geographical, and economic barriers. She is principal investigator on 2 multi-million federal health resources and Services Administration funded projects. Joining me as co-moderator is our colleague, Dr. Jason Morrow. Dr. Morrow is an associate professor of medicine at UT Health San Antonio, where he is also the Howard and Betty Health Professor of Medical Humanities and Ethics. Dr. Morrow is a faculty member at the Center for Medical Humanities and Ethics. He holds a PhD in medical ethics and humanities. During the pandemic, Dr. Morrow joined the Crisis Standards Committee for the South Texas Regional Advisory Council. In this role, he joined me and others in developing ethically and clinically sound guidelines to support clinicians and health systems throughout our region in their COVID decision-making. I'm looking forward to what our distinguished panelists have to say tonight and what they have to teach us. We're going to start with Dr. Patterson. And I've asked Dr. Patterson to spend some time telling us how vaccine trials are designed and what goes into creating a vaccine. And he'll tell us how it's usually done and compare that to what we've had to do in order to respond to this global pandemic. Dr. Patterson?
Thank you, Dr. Bergeron, and it's really my pleasure to join this distinguished panel tonight and for me to give a few words here at the beginning about the about vaccines and vaccine trials, right? So it's important for us to understand sort of the groundwork of where our opportunities are and what are our challenges in this arena as we discuss the ethical challenges in their distribution and allocation. So here's what I was going to focus on in my brief remarks, and it'll be a few key questions. So what timelines are expected for vaccine development? What are vaccines? How are they? What do they do, right? What strategies will be used in these COVID-19 vaccines? Will they be different? What's the difference between some of these vaccines? A brief word or two about ongoing vaccine trials. We're all inundated with the news about the vaccine trials on a minute-to-minute basis, right? With updated results, which we've not really seen except for press releases. But I'll spend a few moments talking about that, and then close with current status of the vaccine development, as well as challenges and responses. So here's a little graphic that shows, just for your sort of baseline understanding about what a traditional vaccine development pipeline would look like and what it looks like in COVID. Everything's accelerated, right? Although it seems to last forever, it's also kind of accelerated. So if we look here at the top, the traditional development takes the materials. It basically does design and exploratory studies in preclinical settings, in animals, but in test tubes, in the lab, looking at various sort of immune responses, right? and that takes years. After that happens, then we end up with a process development that looks at preclinical toxicity. It's really important for us to establish, are these vaccines likely to be safe in humans? There's no guarantee, right? But it's a hope that they would be safe and effective by looking at those. So that'll usually take 2 to 4 years. And then what's called an IND, investigational new drug application submitted to regulatory bodies here in US, the FDA, and in Europe, the European Medicines Agency. And then we go into clinical trials. So the phase 1 trials usually last 1 to 2 years. And those are mainly aimed at dose. We want to give the right dose. We want to give an effective dose. And it looks at safety. We want something that's obviously a dose that's effective, but seems to be safe. That then goes in for several more years to what we call phase 2 trials. So these would be trials in the hundreds of people that will look at efficacy, but for also safety. But a preliminary look, they won't be conclusive sort of trials. And then finally, we'll do phase 3 studies that will involve thousands of patients to confirm efficacy and look at long-term safety. And then something called a BLA, a biologic license is submitted. Then that basically leads to regulatory review by the FDA or the EMA, the European Medicines Agency. That usually takes maybe a couple of years, right? But you don't produce vaccine until all of those are done. Well, where does COVID fit? Well, one thing with COVID, we had pre-existing, at least early development from the earlier SARS. This is SARS-CoV-2, right? So this is SARS-CoV, we didn't call it 1 back then, but it was the original SARS outbreak. And then the subsequent outbreak that we still see occasional cases of MERS, that's a related coronavirus. So those kind of jump-started development, if you will, but those were not approved. So that allowed it to move on ahead pretty quickly to these earlier studies and allowed fairly rapid multiple trial designs to go on at the same time. So phase 1 studies looking at safety and the dose, then was quickly paired with phase 2 at other efficacy looks. Phase 1, we look at more immunogenicity. That means, do you make antibodies that might protect against it? It binds the virus, right? So you don't allow it to infect the tissues of patients, or that you might get T cells that also block that development of infection. And then it goes to phase 3 studies. But at the same time, you've heard then, production's already ramping up, right? The BLA submitted. And then with a very rapid review, we know that several companies, 2 companies, Pfizer and Moderna, are both saying they're submitting next week or so to FDA, and that will likely get approval very quick. So the overall timeline really has decreased. So here's our overall timeline. So it's COVID-19, right? The end of 2019, we identified the syndrome. January, we identified the sequence of the virus. That's important to allow these tests to work. March of last year, we began the first in human trials. Those will be our phase 1 trials. And in November, the further clinical trials are being done. So for those of you keeping score at home, you can look at the coronavirus tracker from the New York Times and others. This is one that's easy to look up. You can see various phase 1, phase 2, phase 3 studies, and even limited approval, not here in the US, but ex-US. Some other trials have been approved, other vaccines have been approved on a limited basis, even before the trials were completed, which is pretty incredible, but none have yet been approved for full use, although we're really not very far. So what kind of strategies are we talking about in these patients? So let's look at those just for a few minutes. So the top one is genetic vaccines. That's a new concept. We don't have any approved vaccines in this arena. But this this is called messenger RNA, and it's genetic material that's in the vaccine. So that genetic material is injected with the vaccine that goes into the cell, right? And then that allows the cell to produce whatever this message is telling it to do. And in these 2 vaccines, that's telling it to produce from the SARS-CoV-2 genes, that's the virus, SARS-CoV-2 is the virus. It tells it to produce parts of the spike protein. The spike protein allows it to enter cells. So that spike protein is then what's produced. That tricks the patient, the host, that tricks the patient in thinking, oh, wow, I've got the SARS-CoV-2, I've got the COVID-19. And so then you fire out immune cells, the antibodies and the T cells to fight that off. So that's how those work. So we didn't know early on if that immunogenicity was very strong. We still don't know how long it will last, right? But we hope that it will be a persistent effect, and from early results, that appears to be the case. What about other viral vectors? Some of them, it uses a virus that isn't pathogenic to humans, an adenovirus. Some are pathogenic to humans, but very minimally so. And it basically uses that to carry these genes into the body to, again, trick the cells to produce those proteins that would then cause an immune response. One in Russia called the Sputnik 5 has been approved. A couple that I'll show in a second, the J&J Janssen vaccine and the AstraZeneca vaccine from Oxford, are using that technologies. More traditional or protein-based vaccines, those are several. One of the major ones of those is the Novavax vaccine. And these use parts of proteins, ejecting them in an unusual way or a novel way with nanoparticles that may get more immunogenicity. That's our goal, right? To get these immune responses from the host. And then by doing that, we're able to produce resistance against the virus. So that's our goal. So these use other, what we call adjuvants. They're compounds that further enhance immune responses to produce better responses. And I'll show a little bit of that on the next slide. This last group of strategies in inactivated or attenuated vaccines are ones we've used in the past, like for polio vaccines here in the US, for example. But for SARS-CoV-2, we're not using those strategies here in the US. Those have been used in China and other places, but those are weakened or inactivated viruses, and we're not attempting those approaches. Well, this slide shows the results of a group called Operation Warp Speed, OWS. That means fast, right? So the FAST is basically a collaboration between the government and a private industry. And you can see the companies listed here: Moderna, AstraZeneca, Johnson & Johnson, Novavax, and Sanofi. And they all use these different strategies I talked about on the previous slide. Here, I will say at UT Health, we're a participant in what's called the COVE VPN network. It's the COVID Vaccine Prevention Network, COVE VPN. And that's a group that works in concert with this Operation Warp Speed to produce platforms of vaccines that will be effective. And so you'll hear more about that from us coming up really soon. You see here on this slide, though, is how does this get funded? You see a lot of funding by the government in the terms of billions of dollars, and the European entities as well, clearly funding the Moderna, the AstraZeneca, the Johnson & Johnson, even the Novavax and Sanofi trials in a great extent. Now, in some ways, these are also important to recognize their difference. So the immunogenicity, which I've been talking about, is how the host responds, is really important to look at. And so we'll be looking at that scientifically as we move along. All of these shown here are stored at room temperature, at refrigerated temperature. The one that's not listed on this slide, you're probably wondering, has he forgotten about the Pfizer vaccine? I really haven't. I seem a little slow, but we haven't forgotten about it. But the Pfizer is not part of the Operation Warp Speed. The government has supported it in terms of buying vaccine, but not in the development. So let's turn to that. So Pfizer vaccine candidate is not in Operation Warp Speed. It began only in phase 3 in July, end of July, just a few months ago, and has enrolled almost over 40,000 patients already. The first press release, which is all we've seen of these data, was in early November. And it basically showed after 92 cases, the goal was to see cases in the patients who got vaccine versus those who didn't, the controls, and efficacy was 90%. Just yesterday, the updated data showed in the 170 cases, 162 of the cases were in controls and 8 were in those who received vaccine. That's 95% effective. That's pretty effective, right? That's like our early childhood immunizations that we really think everybody should get. So that would be great. Maybe more than we thought it would be. But that's only at 2 months. So we don't know how long that'll last. We do know that safety signals at this early time point seem good, but that's going to be really important. There's more data coming out about key populations like elderly, even pediatrics, by race and comorbidities. And my panelists are going to talk about those in much more detail. It's also important, are you just preventing severe disease or all disease? That's going to be critical, because if you didn't prevent like mild disease, you might even spread it more, right? So that's something we'll look at. Globally, we're going to see a lot of vaccine coming soon. There'll be a lot of overall about not enough vaccine, but I think we will get a lot really, really soon. And then the real challenge here, though, is this vaccine must be stored ultra, ultra cold. That's minus 80 degrees centigrade. That's what we use in labs, and not really very applicable in primary care settings. What about the Moderna vaccine? It has 30,000 participants. It showed an efficacy rate of almost 95%, 94.5 to be exact, with really not many side effects. We have heard from people that have taken it. They have gotten side effects, but it does seem like it's pretty minimal. Again, it's very early on and yet to be seen. An advantage will be it's refrigerated, but I'll also say that both of those vaccines require 2 doses to be effective. So here's our expectations in reality. A number of drugs, a number of vaccines in clinical trials and early development. First results have just been released. More is coming. But there are a lot of key questions that the panelists here are going to address tonight. Who gets the vaccine? How does it get distributed? And what about global distribution across the whole world? There are a number of challenges and responses. Clearly, Operation Warp Speed has been good, but there are a lot of logistic challenges in that, I'll just tell you. The logistics of rapid trial enrollment has really been something else. The emergency use authorization is what we're going to likely see first. It's not final approval. And so that's going to be important to really understand what it means in terms of efficacy and safety. We have to address vaccine hesitancy across the board. People are anxious. We want to make sure vaccines are effective, but they're also safe, right? And then finally, we got to have equity across with clinical trials and people of color. At the Health Science Center at UT Health, we have formed from President Henrich a COVID-19 vaccine assessment and access task force. So we're really very aggressively addressing these issues on our campus. So will trial participation impact the ability to receive other vaccines? It could. It's going to be important to sort that out in developing these trials. Should some people avoid the trials and wait for the approved vaccines? That's not really clear. I think the vaccine trials still offer a lot of opportunities. We don't know how long immunity will last, but we do know that herd immunity would result in hundreds of thousands of deaths. We cannot afford to not vaccinate our people if we have it. So I'll stop after this. Take home points. It's a crazy timeline of science, incredible progress so far. Please remember safety and efficacy. Inclusion of vulnerable populations is really key. And like a sign down in my neighborhood in King William says, no te rindas, don't give up. We're making progress. We don't feel like it, guys, but I do think we are. And that I'll thank Barbara Taylor for a number of these slides. My clinical trial team at UT, Robin Tragus is our lead. But our teams at UT Health and University Health, our research support teams, have really been incredible in this process. San Antonio should really be proud, but our patients with COVID-19 deserve the credit for their enthusiastic participation. And with that, I'll stop and give it back to the moderators. Thank you again.
Thank you so much, Dr. Patterson, for that whirlwind overview. We really, really appreciate your breaking these complicated issues down for us and helping us get to a level playing field with some at least basic knowledge. Could I ask you to clarify a point that you made there towards the end? You made a comment about herd immunity, and you said herd immunity would lead to many, many unnecessary deaths. Can you tell me what exactly did you mean by that?
So herd immunity, Dr. Bergeron, for the audience is really, as you know, when you get to a certain percentage, it's usually maybe 60 to 70% of the people infected or vaccinated. And so, to get to that level, our levels in most communities is way, way under that, maybe tenfold less than that, maybe more, but still way less than that. So to put it in more blunt terms, is the question, should I just go out and get this, get it over with, and become immune? Well, one, we don't know how long you'll be immune. But second, we don't know if you're going to die with it when you get it. And so that's something we just cannot afford to do, right? We really have to develop a more measured and clear strategy for this infection. Thanks.
Right. So waiting for us to naturally become immune by letting the infection rip through our population, although those who survive would have immunity for some unknown period of time, we'd lose a lot of lives along the way to getting to that point. Okay.
Absolutely. Yeah.
There are a couple of other clarifying questions where we aren't going to get to all of the vaccine questions right now because we're going to save a lot of the questions for the Q&A at the end. But somebody texted and wanted to know about the mRNA vaccines. Aren't those dangerous because don't they get into your genetic material and alter your cells for the rest of your life? Isn't that very scary, especially since we haven't done this before?
Yeah, they really don't. That's the idea of them. They don't stay there forever. It's not that's not what's happening. They, do their business and get out of there kind of deal. So I think they're going to be safe. They're a new platform. They appear to be safe so far, but clearly that's an important issue for us in vaccine development.
So the mRNA doesn't insert itself into our DNA, what I think I hear you saying. All right, we'll come back to many great questions about vaccines in a bit, but first we turn to Dr. Matt McCarthy. And I've charged Dr. McCarthy to think about his role on the ethics committee and as a COVID doctor and expert in dealing with this infection. Help us understand, Dr. McCarthy, what are some of your ethical concerns about the way these trials have been designed and rolled out? What are you grappling with in your hospital's ethics committee about who gets vaccine and when? And even if we could stretch beyond the limits of your hospital and that decision making and think about the world and getting this vaccine dispersed across the planet in an ethical and equitable way. You have a lot to talk about and we're looking forward to hearing your comments.
Yeah, I'm going to try to cover all of that in 10 minutes. It was great to hear from Dr. Patterson, laying out so beautifully where we're at Operation Warp Speed. I think to sort of drill down into where things go from here, what's going to happen is that Pfizer is going to apply for emergency authorization tomorrow. And then what happens in the next couple of weeks is going to be really interesting to see. It's very important to know there's a big difference between authorization and approval by the FDA. What we're looking at is Moderna and Pfizer applying for authorization, which basically means this thing is still not a fully approved vaccine. It's still investigational, but there is a preponderance of evidence to think that we should roll this thing out more widely. And the way that this happens, the nuts and bolts of it, is that the FDA has an advisory panel of vaccine experts. And I can tell you they are legit experts who I would trust my own medical care with. They have been told to clear their schedules for December 8th, 9th, and 10th. So the likely what's going to happen is that on this, and it's going to be a public viewing of their debate over the data. And as Dr. Patterson mentioned, we've only seen the press releases so far. And people like me are very wary of practicing medicine by press release. These things never live up to the hype, whether it's been remdesivir or whether it's hydroxychloroquine or the serology tests. All of these things we keep hearing are game changers turn out not to be once we see the real data set. And what I'm getting at here is that you might hear that a vaccine is 95% effective, but then you look at the subgroup analyses and you see that it's 99.9% effective if you're under the age of 60, but only 50% effective if you're over the age of 65. And there are all of these subtle permutations that we are going to dive into, likely December 8th, 9th, and 10th, along with this advisory panel. And from there, they will make a recommendation to the FDA about emergency authorization. And as soon as that happens, the CDC is going to, within 24 to 48 hours, get their expert panel together to make recommendations about who should get priority and who are the groups that should go first. The things we've been hearing about are people in nursing homes, people who are in long-term care facilities where the mortality rate is extraordinarily high, and then high-risk people who are healthcare workers, people like me, people who I've treated over 500 coronavirus cases. That's what I've been doing every day for the last 8 months. And should people in the ICUs, which are even higher risk. And they're going to make these recommendations, but then we have to get down to the nitty-gritty of saying, okay, within a group like healthcare workers, who actually gets priority? And this is where my ethics committee has been meeting, and ethics committees around the country have been trying to put into accessible language some core principles. A really important paper was published back in May. The lead author was Ezekiel Emanuel, who's a prominent bioethicist who's now on Biden's coronavirus task force. And his group laid out some ethical principles for who should be getting these vaccines. And they put, it almost seemed like a value-based decision system here, where people who are healthcare workers should get priority. People who had volunteered for coronavirus research should get priority. And they deprioritized young people. And that's something we've been arguing about. And just on a very practical level, who should get a vaccine first? A 65-year-old doctor or a 29-year-old doctor who has 2 kids? You can make an argument for each one of those, but we've been sort of going through those things in very fine detail. The other thing that's happening, there was an article published yesterday by a group in UCLA where they're arguing for distribution within various communities, saying that we should factor in things like socioeconomic status, ethnic and racial minorities, structural barriers to accessing healthcare. And they put out a plan which very clearly shows that the vaccine should be given preferentially in certain communities. And many of them are communities of color. And what we talk about in our meetings, which I'm really interested to hear how people in the audience and panelists think about this, is that on the one hand, you could make an argument that people of color should be getting priority because we see that the death rate is frankly higher than they are for certain other groups. On the other hand, this emergency authorization means the vaccine is still experimental. And in a way, you could phrase it in a way to think this is experimenting on people with a vaccine that has not been fully approved. And there's a long history of experimenting on people of color. And so these are the kind of conversations we're having right now of how do you, once groups have been identified, roll this thing out. The other part of this is that we have no idea how long vaccination gives you protection. And we don't, frankly, know which one of these vaccines is the best, because one of the things that happened in Operation Warp Speed is there were not head-to-head trials of Pfizer versus Moderna versus Johnson & Johnson. They each got to run their own trials that were a comparator to just a placebo. So in a sense, they can all declare victory. And Dr. Patterson mentioned that Pfizer is not part of Operation Warp Speed, which is technically true. And they made a very prominent point of saying they didn't take any money to do that. But if you looked at the slides that talked about how you make a vaccine, there are typically 40 go, no-go moments in the process of making a vaccine where everyone will stop. They'll look at preclinical data. They'll look at the market share for their potential vaccine, and they'll say, do we go forward? Yes, no. And that happens roughly 40 times for every vaccine. All 40 of those moments have been removed from the process because of the financial incentive that the government has created, where they said, we'll give you $2 billion for your vaccines, regardless of whether or not it's the best vaccine. So that's how we've been able to develop these things so quickly. And I think the name Operation Warp Speed, on the one hand, is exciting and invigorating of how quickly these things have been made. But on the other hand, people are saying, this was fast. Was it too fast? And do we need to actually slow down here? Because in research that I do, we're fond of saying that fast is slow and slow is fast. And what we mean by that is the faster we try to push something, the more it ends up slowing things down. And when we take our time and we try to get really good messaging, we do a lot better job. The other part that's really important to understand here is that these trials were designed to address symptomatic COVID. So what they were looking at is how many people in these trials were developing moderate to severe disease. They weren't looking to see if people were transmitting the virus. Those are two separate questions. So when we see the data, what we're hearing is there are 170 people in the Pfizer study who developed symptomatic COVID. And of those, 162 of them were in the placebo group, and only 8 were in the vaccine group. That's wonderful, but that's not looking at the rate of transmission once you've gotten the virus. We do believe that if you can decrease symptoms, you're going to likely decrease transmissibility because you're often highly contagious when you're having symptoms. But that's a separate question. And so what we'll have to talk about in the messaging that I'm already working on in New York State is the idea that we will tell people, you've gotten a vaccine, but you still need to wear a mask. And a lot of people are shocked by that suggestion, and they think that it's some sort of, control that we're trying to have over people's lives. And it's really not that. It's just that these trials weren't designed to stop transmission. They were designed to stop you from getting really sick and dying. And another way to look at it is, rather than saying 94% effective, 95% effective, the thing that I key in on when I see these press releases is how many people in each group got severe disease. How many people got really sick? And for Moderna, it was 11. And they were all in the placebo group. So that's a really good sign that nobody in the vaccine group got really sick. For the Pfizer, it was 10 people got severe disease, and 9 of them were in the placebo group. So that means there's one person out there who got Pfizer's highly, highly effective vaccine and still got really, really sick. And what we don't know is how things are going to play out in the real world when we start rolling these vaccines out. And people go on social media and say, I got Pfizer's vaccine and I ended up in the ICU. We hope that that's not the case, but those cases are something that we are thinking about already with the messaging. One of the final things I'll just say before I run out of time is these vaccines are largely being tested in healthy people, ambulatory people, but many of the people we want to roll them out to, people in long-term care facilities, may not reflect exactly who's being studied. And one of the groups that has come up in questions is, should we be testing prisoners? Because we see that in jails and prisons, there are these huge outbreaks. These people are at incredibly high risk. And there's an ethical challenge of doing experimentation on prisoners. There is a long and sordid history of infecting prisoners with viruses, with testicular implants. San Quentin in the United States has a horrible history of doing this. And so on the one hand, as a scientist, I absolutely want to study this group. But as an ethicist, I pull back and I say, we should not be running trials with prisoners. And we really, this is such an opportunity to exploit people that we can't do it. And so these are some of the ethical dilemmas we are wrestling with right now. And then the final point I'll make is, how do we, on a broader scale, get the most effective vaccines in the most people? And it's been mentioned that Pfizer and Moderna are in the lead right now, but their distribution is going to be really cumbersome. So they have to be kept at sub-zero temperatures. And that's because RNA is an inherently unstable molecule. And they require 2 dosages. When you see a 95% effective in a press release, that's best case scenario. That's in a study where people are being encouraged to follow up. There are people who are paid to make sure you come back for your second dose. We don't know if people are going to do that. And some of the other vaccines that are coming out later may be more simple to vaccinate people with. So Johnson & Johnson can be refrigerated, and it's just 1 dose. That's the one that, I have no financial stake in this. That's the one I'm rooting for. That's one that I can envision being deployed all throughout sub-Saharan Africa. I don't see Pfizer being able to do that. And so the vaccine that gets approved first, history tells us, is rarely the best vaccine for the given virus or the given disease. So this is a great first step. I'm blown away that in 1 calendar year, we've gone from sequencing the virus on January 10th to looking at emergency authorization on December 10th. But there's still a lot more to go once we get that first hurdle of saying, okay, we can start deploying these vaccines. So a lot of stuff to talk about with the ethical issues that we are doing behind closed doors. And hopefully we're going to get some guidance soon from the CDC and from the FDA about how to start actually rolling this out.
Wow, Dr. McCarthy, that's very provocative. I'm interested in understanding what is the status of this biologic, right? Dr. Patterson says that when the FDA formally approves something as opposed to authorizing, you made that distinction for us. When they approve it, they issue a biologic license. So if this vaccine from Pfizer is authorized to be used for people, is it at that point still investigational? Will we still study people and the outcomes? I worry about, in the traditional route, there's these years and years of watching for side effects from the vaccine that could be delayed, right? The adverse effects from the vaccine, if we have this foreshortened process where it starts to be delivered to people, will we still study it and get to see if it's causing harm? And will that affect whether or not the FDA ultimately approves it?
Well, I mentioned that there's an advisory panel that's guiding the FDA, and the FDA has said they want 2 months of follow-up safety data. And that advisory panel, some of the members have said, we want to see at least 4 months. So already there are some breakdown in terms of the consistent messaging of how much information do we need before we roll this out. I see interviews with medical officers and CEOs for Moderna and Pfizer, and they say every day that we're delaying, 1,000 people are dying, 2,000 people are dying. So you can have all of these, academic discussions about the subtleties of authorization versus approval, but we need to get these shots into people's arms to save lives. I consider emergency authorization as them saying, this looks pretty good and safe enough to start rolling out, but not a definitive licensure, which is something that really puts their integrity on the line. And, I wrote an article recently saying that I don't know if emergency authorization is the way to go, because we have seen several missteps along the way where hydroxychloroquine got emergency authorization, where serology home blood tests got emergency authorization, and those were later rescinded because it turned out that the data didn't hold up. And so you have to be very careful explaining to people what this actually means. I'm somebody who, I get my flu shot every year, and I'm very supportive of vaccines, and I encourage everyone to get them. But we just have to make sure we know what we're telling people that emergency authorization means. There's only been one emergency authorization for a vaccine ever, and that was for anthrax back in 2005. So this is a very new territory for doing this kind of stuff.
Well, if you agree to take this vaccine under emergency use, are you consenting to a treatment like a protective treatment that you would normally consent to? When you get that flu vaccine every year, you are offered a treatment, a protective treatment, and you consent to take it. And there's this being informed about the disclosure and the risks and the alternatives. And there's this process. When you're involved in research, when it's investigational, then there's a different kind of consent to participating in research. You know that it's not just for your benefit, but for science. What is this status of this biologic that is neither an approved treatment nor part of a study?
Yeah, it's a gray area. It's one that I certainly have no professional experience with. As I said, we don't offer emergency authorizations of vaccines in any kind of routine way. What I'm thinking about as you talk about this is the conversations that we're going to have in nursing homes, where we're going to say, okay, we've got the coronavirus vaccine, and we should probably have a conversation with you about it. And you're talking about, mRNA and multiple dosages and neutralizing antibodies, or maybe you're not talking about it. Maybe you're just saying we're going to give this to everyone unless you say no. And how does informed consent take place when the information is changing or the information is incomplete? This happened to me when I was on the wards back in March, and we were trying to figure out if we should give people dexamethasone or steroids. How do you get informed consent from somebody where there is no data yet? And as I've said before, people have unquestionably died in my care because they didn't get steroids at the time because we didn't have a recommendation to do that. And there were people who wanted to do it. They were told they didn't have the evidence, and we didn't have the information at the time. And so I think that what you're hitting on is a crucial aspect here of how do you have informed consent with people about a vaccine that has authorization but not approval. And we haven't figured that out yet. More to come on that.
So one final question before we move on to our next panelist is, let's say that I am hesitant and I don't want to get a vaccine under the EUA. I prefer to wait until there's authorization. How long am I likely to have to wait?
Oh, they haven't put out a timeline for this yet. I don't know, Tom or Wari, if you have any sense on when actual licensure is going to take place. I would expect it to be a year away, but I don't have any firm information on that. I wouldn't blame you if you said you wanted to wait. As somebody who routinely is in the line of fire, I put on a mask, I put on an eye shield, I wear PPE, and I feel safe. I'm not somebody who is counting the minutes until I can get a vaccine. I'm going to believe in it firmly. I believe in the advisory panel, but I would certainly respect your decision as somebody who says, I want to see a little bit more information. That's reasonable.
But if we all did that, we'd still be looking at this 2 new cases every second and a death every minute, wouldn't we?
Yeah.
All right. Well, thank you. Thank you so much. And I know we'll have plenty of questions for you and we'll be coming back to you. I want to turn now to Dr. Wari Allison, and I've asked her to prepare some comments about how do we address the challenge of equitable vaccine distribution to marginalized communities and vulnerable populations, and what potential tools are available to prevent the misallocation of vaccines. How do we address mistrust, not only of clinical trials, but of vaccination itself in underrepresented minorities and person of colors? And finally, if you have a chance, we'd like to hear, and I've seen this in the chat, why are children left out and when do we expect them to get their vaccine? So Dr. Allison?
Yeah, so thanks. I'm part of this assembled group that's been mentioned of experts at UT Health San Antonio, forming the COVID-19 vaccine assessment task force, and I'm in the ethics subgroup of that task force. And further, my work as a physician scientist for the last 15 years has focused on access to care for marginalized populations. So this question of how we address equitable vaccine access and distribution to marginalized populations really resonates. The first thing is we have to recognize that that change in the traditional ways of vaccine allocation is necessary. And that change needs to be that we have to include race and ethnicity, whilst recognizing that race and ethnicity per se are not the causes of health inequity. And people who've heard me talk about this know how I emphasize that it's not your race and ethnicity that gives rise necessarily to the inequities per se, but it's the social determinants of health that are entwined therein. And so if we don't collect those data, and if we don't look at that when we're trying to figure out how we're going to allocate vaccines for COVID-19, that it is kind of inevitable that vaccine allocation will be inequitable. When you consider vaccine allocation, you can I think about different population groups, and there are different ways to divide up populations. I think of healthcare delivery organizations and frontline organizations. And then the second big group I think about is the organizations that are delivering essential and other services and businesses. And then I think of a third group, which is kind of the general population, who may be included in those other larger groups. And there are a number of different ways, different tools to consider to prevent misallocation. But what I want to focus is one, and I want to focus on community engagement. What does that mean? It means that we need to have representation by and conversation with community leaders and stakeholders, and that's critical. And who those people are will differ from community to community. So even where I live in San Antonio, from the east side to the west side to the north side to the hill country, the communities are different, and so these community leaders are going to look different. And it's also important to recognize that we're not going to have a one message fits all, which as a public health professional, you know, for health promotion messaging, that would be ideal for me. But that is not what's going to happen because of these different groups. And we're going to have to tailor what the message is, who's delivering the message, and also consider different languages. In my community, it's going to be Spanish. In other parts of the country, it will be different languages. And just to give an example of why it's important to listen to the community, we all recognize that that nursing home residents are at risk because they're elderly. So if you go, right, if I need to allocate vaccines, the priority populations are elderly people. A priority population is elderly people in nursing homes. We need to get to all the nursing homes in the community. But if you then don't recognize that in some communities and culturally and in some ethnic groups, nursing homes are not acceptable and it's not something that people do, then in those communities, all these elderly people are not going to be in nursing homes. They're going to be in multi-generational homes. They're going to be at home. And so you're going to miss them. And so this is why it's really important to communicate with the community. Then to address this question around mistrust of clinical trials and vaccinations in underrepresented minorities and persons of color. So I'm going to quote Ann Dills of Texas Department of State Health Services, because we had a symposium yesterday around HIV. I'm an HIV physician, around HIV, substance use disorder, and HCV. And Anne was talking about storytelling and communication related to HIV. And she said this, and I'm going to quote her directly. She said, "People don't care how much you know until they know how much you care." And so who is delivering the message of vaccine-related information is very important. And then furthermore, how vaccine-related information is delivered is important. It is scientific data, obviously it is, but we have to make those data accessible. We have to make it engaging, and really importantly, we have to make it understandable. And then additionally, we have to create and maintain a space for those communities to be part of the story, and not part of the story in that we need to give them information, but part of the story because we also have to learn from them as scientists and as public health professionals. And some of that learning from the community will be formalized, right? Will have to be formalized in terms of, structured surveys, serial surveys, focus groups, and we rely on our social scientist colleagues in doing that. I also want to talk about stigma. Again, I'm an HIV physician, so stigma is very front and center of what I do. And I think we have to understand that we are going to have deliberate strategies to combat stigma. And stigma in terms of vaccine access and distribution could be related to lots of different things, but I just want to focus on language and messaging. So the language that we use and the way we deliver messages is going to be really important. And again, to give another example, are we going to stigmatize people for not taking this vaccine? And similar to what Dr. McCarthy said, I'm an ID physician, I'm for vaccines. I am 100% for vaccines, but this vaccine is a little different, right? And so are people going to be stigmatized as anti-vaxxers if they don't take this vaccine, which, as Dr. McCarthy and others have mentioned, will still essentially be experimental when we distribute it. And I think we have to just be careful around stigmatization. And then finally, I just want to touch on this question about, I'm not a pediatric ID physician, but about why children are left out and do we expect them to get the vaccine? So one paper, one scientific journal paper mentioned that as of the 1st of June 2020, there were 124 candidate vaccines under development. And of those, there were 10 that were in phase 1 clinical trials. And that information is obviously out of date because we're now in November. But the point I'm trying to make is this, that out of those 10 in phase 1 clinical trials, just 2 were enrolling children at that point. So one was enrolling children greater than or equal to 3 years old, and another was enrolling children greater than or equal to 6 years old. And the maximum age there wasn't a maximum age limit. And so my point is that there are less trials for children. They are going on, but there is going to be a lag in data emerging about safety and efficacy for children. This is not unusual when it comes to drug development or vaccine development, when the disease is not focused particularly on the pediatric population. And so we will see a lag. I can't predict how long it will be, but hopefully it won't be too long. There's also, I was asked to address this question about, will herd immunity be slowed down, acquiring herd immunity be slowed down if we don't vaccinate children. So Dr. Patterson defined herd immunity. And when you look at those percentages required to reach herd immunity, the denominator, so denominator fraction, a percentage is a fraction, right? The bottom number is the denominator. The denominator is all of the population. It's not, it doesn't exclude children. So when you take a group out of the denominator, the fraction, the percentage is going to be higher. So obviously you're going to then require a higher percentage, right, to reach herd immunity. But I think another really important thing to think about is you think of populations in different ways. So we have the population of the United States, but we have subpopulations, and subpopulations have different numbers of children in them. And it does, again, come down to community. So a retirement community in Florida, for example, would not have many children in that community. And so herd immunity in that subpopulation is different to when we're talking about herd immunity for the entire United States. So I think that's also important to think about. I think I've answered everything that I was tasked with answering.
Thank you. That was beautifully done. And thank you for helping us think differently about our country. And we tend to think about these big, broad groups, but maybe we should stop thinking about just racial and differences and minorities and start thinking about within individual communities, how we need to approach them differently based on their composition. I did have one additional question for you, and this was sent in by our colleague, a pediatrician, Dr. Rachel Pearson. Rachel asks, what steps can health providers take to ally with patients of color who have concerns about vaccine safety? And along with that, should providers ask about patients' prior experiences of injustice or their concerns about injustice?
So I think one really important aspect of allying with patients is building of trust. And so, if you haven't got that relationship already, you may not be in a position to ask your patient deep questions. But if you have got that relationship, I think a big part of allyship is listening. And we're all challenged with that because it takes time to listen, and we're all trying to keep to schedule in clinic, right? And so that's always a challenge. But I do think questions should be asked, and sometimes I try and flip it the other way. So get the patient to ask me questions. So put it this way. So rather than ask a specific question, say, do you have questions for me about anything that's concerning you about HIV or the COVID-19 vaccine? And then that allows them to kind of ask questions. And I think if you are asking specific questions, it's better to make them open-ended and say, oh, is there anything that's worrying you about the COVID-19 vaccine, as opposed to have you experienced any racial injustice or any other type of injustice, to not be that specific. I think keeping it open then generates conversation and then generates an opportunity for you to listen. And I think a big part of allyship is creating space to listen to your patient.
Thank you so much. Well, we've now entered our Q&A period, and we have just under half an hour to address your questions, and they have been pouring into the chat. And what I'd like to do is to alternate with Dr. Morrow. And I've picked out a question that looks pretty close to the top of the list after you scroll past all of the questions about CEUs. I don't forget, you can email the Center for Medical Humanities and Ethics at that email address we've been putting in to get all of your final questions about CEUs answered, and we will do our best. But we see a question here from someone who asks, what is the consequence of immunizing an asymptomatic carrier who may have antibodies in a mass immunization? Will there be a hypercytokine response? In other words, I guess it's two different kinds of questions, right? What if you already have the infection, but you're asymptomatic, and now we immunize you? And then what about people who may already have some immunity, and we come and we provoke you into a response with an antigen, a protein, the spike protein? Will you have an overwhelming inflammatory response? And I think I'm going to pitch that question first to Dr. Patterson, and certainly ask Dr. McCarthy if he wants to weigh in.
Yeah, so that's a good question. So do people that had prior infection or antibodies, in other words, would they have potentially a bad effect, right? It's not 100% known that you wouldn't, but there isn't any evidence that would happen. In the trials that have been done, prior infection or antibody is not an exclusion, is not really checked. And so it actually might be favorable. That could happen. The question could also be a little different. What about children that might have high antibody levels that have the multi-inflammatory syndrome? That's potential, I suppose, but again, that really hasn't been borne out and is unlikely to happen. It hadn't really been reported. Matt may have further insights on that, but I think that really you might even get a better response having previous exposure, frankly.
Yeah, it's a theoretical concern, and this is when you hear doctors saying we want to see the data and we want these trials to finish. This is one of the reasons we want them to finish. When Moderna has enrolled 30,000 people and they tell us what happened to the first 100 of them, we all want to know what happened to the other 29,000. And that takes time to develop. And we assume that with all of these trials going on, the hundreds of thousands of people who are going to enroll in them, that somebody is going to be in this position where they're an asymptomatic carrier and they get vaccinated. All of that stuff is going to take time to tease out, where you're going to have to wait and say, okay, of the 95,000 Americans who got vaccinated with one of these experimental vaccines, how many of them developed cytokine storm? And of them, what do we know about their background? And what do we know about the vaccine that they got and whether they had symptoms at the time? And that's the kind of stuff that goes into the full licensure and authorization. And that will not be completed next month when we get this emergency authorization. So I think that in plain English, what I would say is it's a theoretical concern, but it's not one that I'm actually worried about happening. And we will know for sure about probably 6 months or 9 months from now when they've gone through all of the data.
Could you make an argument to test people's nasopharyngeal swab PCR at the time of getting vaccinated, so we would at least have that baseline information, or is that simply not feasible because of logistics?
Probably not feasible, really. It's something that you don't want to be vaccinated symptomatic people, right? Because this is going to be a problem. But in trials, you do get a negative swab before. So we know the patients in the trial, the subjects didn't have active disease. But to add just a quick note on these trials are aimed to last for 2 years. And so hopefully in some form or fashion, parts of them will, at least for safety, because that's going to really be important for us to know, as Matt says, what is really the long-term effects of all these vaccines.
There's so much uncertainty about COVID that's certainly understandable, right? It's only been around for a little while, but we've got experience with influenza. People get influenza vaccines, even if they already had it that same season, and whether they knew it or not, right? So do we have evidence of people being harmed or benefited by getting vaccines and with regard to influenza, and can we extrapolate?
You could somewhat, but SARS-CoV-2 is a little different, I think. There's some theoretical, at least concerns, as Dr. McCarthy says, about how you could have antibodies that make you worse. It's a very theoretical. It's not really been proven, but I don't think those are really borne out in influenza.
Yeah, you know, early in the pandemic, we extrapolated a lot from influenza to make decisions about coronavirus, and many of those decisions turned out to be bad ones. You know, we don't give steroids routinely to patients who have symptomatic influenza, and I wish that we had. And so it's a great point that, you know, if we're not seeing this with other viruses, why would we have this theoretical concern here? But I just caution us to extrapolate from influenza after having been burned by it earlier in the pandemic. But it's just a fascinating situation that we're getting in December. We're going to have this snapshot of a very early signal from the trials of what may be working or what may not be working. And in any other situation, we would wait. But so many people are dying that we can't wait. And so how do we actually move forward in a responsible way is what we are all spending every waking hour and every committee meeting trying to figure out. And what's going to be interesting is seeing what actually is the principle that, or the principles that we use to guide us to make sure people get this. So more to come.
Well, Dr. McCarthy, I love that question of the ethical principles that we're trying to balance in this really big public response. And I'm gonna come back to that because we have another question in the chat about the viability of successful distribution of a vaccine that requires Antarctic conditions. So I could pitch that to any of our panelists, and including Dr. Bergen, co-moderator. When we're trying to distribute something that has such sensitive and high-tech requirements that require their own industrial manufacture, what does that say about the viability of that particular vaccine distribution, and what does it mean in terms of strategy of where that particular vaccine with its stringent requirements, where it might be prioritized and targeted to?
Let's pitch it to Dr. Patterson in your role as the chair of our university's vaccine working group.
Yeah, it's a super question. You know, it's a real challenge. You know, there's apparently been sort of a run on -80 freezers. They're very expensive. And dry ice. You can keep this at, you know, this is the temperatures of dry ice, right? So you can keep these vaccines on dry ice for a number of days, actually. But it makes a super big challenge because how will you then be able to do this in remote sites? How would you do it in, really, frankly, primary care clinics who don't have these kinds of freezers? They don't have space for them. They don't have the ability to do that. And so I think it's going to make the use of that first Pfizer vaccine really a challenge in that way. You know, at the university, we have these freezers in our research labs, and we have them that can be, you know, redeployed for these purposes. So it's possible for sure, but it's going to be a challenge across the globe without a question.
What about having mobile vans with smaller sized -80 freezers or tanks of liquid nitrogen to take small amounts of vaccine out to neighborhoods and just immunize by appointment a certain number?
Yeah, I think that's what you're going to have to do. If you look at even dry ice, if you take it out in the community, for example, in mobile vans, it's a great idea, right, to reach a lot of populations of people. Then you thaw it. It takes a significant amount of time to thaw. Then you got to deal with multiple dose vials. In other words, you draw a number of vaccines from the same vial, or just single dose. You draw one dose from the same one vial. But then you can only use it for a certain period of time. We've been told, we may learn more, but we've been told that's like 6 hours. You got to be pretty organized, right? You got to have people lined up, ready to come get the vaccine, or you're wasting a bunch of the stuff. So there's a lot of logistical challenges. So we have to think about these.
But if we put our heads together, we'll figure something out. I see Dr. Allison raising her hand. Please speak up.
I think it's really important to recognize that is just not going to work in certain communities. So, for example, rural and remote America, you know, having a van will work in an urban setting. But, you know, if you talk about rural America, where it takes 2 hours or 3 hours or longer to, you know, between places and between places that are habited, it's just not going to work. And even though right now we are focused on the United States, I do global health work. A lot of people do global health work. And I think none of that is going to work in a resource limited setting overseas in sub-Saharan Africa or in India or in places like that. It's just going to be too difficult to have -80 for a prolonged period of time. So there'll be a lot of groups that won't be able to access that vaccine.
Well, I think the other point that Dr. McCarthy made was, many of these vaccines, maybe there's one exception so far, but to require 2 doses is also a logistical challenge, right? To reach people that aren't necessarily in healthcare and hope that they get the first dose at day 1 and then they get the second dose in 3 weeks. This is kind of a problem, right? So we really have to address that.
Could you comment, Dr. McCarthy, on why you can't mix and match? Why couldn't I get Pfizer vaccine #1, and if it's just more convenient or because of supply and demand, I get my second vaccine 3 weeks later from Moderna? Why wouldn't that work?
The sequences that they're using are slightly different, which means that the immune response you're generating, we expect to be slightly different. And we haven't tested anyone mixing and matching, so we don't know how much overlap there would be. And we just can't take that chance. I think that as you are all alluding to, it may be that many people are in the position where they just have to wait a few weeks or even months for a more easily distributable vaccine. I'm seeing health commissioners in Mississippi and in the Dakotas that are saying, we don't have the resources to distribute a sub-zero vaccine. And you're going to be hearing more and more about that. For New York, what Governor Cuomo said was, it took us 7 months to test 12 million New Yorkers, and we need to vaccinate 20 million with 2 doses. That's going to be way harder than just sticking a swab in someone's nose one time. And this is something that is going to be a monumental challenge. And I think and that's in a place that's got a lot of resources and a lot of densely packed people who could be, lining up to get these vaccines. So I think we'll be talking about the distribution issues for a long, long time.
Well, while we're figuring those things out, we still have a lot of work to do in educating our public. And there's a question from Reverend Dr. Kenneth Kemp, who's a critical care specialist in addition to being an ordained minister. And he is very much in the business of communicating with people. And he emphasizes that there really are people putting out erroneous data on the internet suggesting that the mRNA is incorporated into the human genome. How do we approach the problem of health literacy with respect to this particular issue, which may be contributing to hesitancy? And any of you might want to take a stab at it, but we haven't heard from Dr. Allison for a moment. So would you like to start us off?
Gosh, it's really difficult. One of the things when you're trying to put out a public health promotion message is consistency in your messaging. And we have not had consistency in our messaging, our public health messaging about COVID-19. And so when you don't have consistency in that messaging, it gives non-legitimate sources opportunity to get the ear of the public. And I think that is happening more than it should, just because of this lack of consistency of messaging. And so I think one of the things that we must do is have a united front when we come to the messaging about this vaccine. We can't, or these vaccines rather, because they're different ones, we can't all be saying different things because that will just be, I don't want to be dramatic. I was going to say disastrous, but that sounds so dramatic, but it is dramatic. It will be disastrous if we are not consistent with our messaging. So that for me is the most important thing, that that we give consistent messaging when it comes to these vaccines. And if we do that, then it's less opportunity for these erroneous sources to get the ear of the public. And you can't control social media, right? It's just a vast thing. It's a beast in of itself, and so you have to have the right messaging also out there competing with these erroneous messages.
terms of giving the messages, it's interesting to think about, social media. It's like you said, how can you talked about trust and knowing that the person who's making the recommendation to do something is trustworthy, cares about you. So the internet doesn't care about us, and Twitter doesn't care about us. So we have to find a way to message responsibly. So consistency matters, but it also matters to put the right people and the right voices out there. So I appreciate that. I have a question coming from the chat, which asks about when can a person donate plasma after they've recovered from COVID, and I guess I wonder, and if a person has gotten it, should they line themselves up for the vaccine? What if they are themselves identified as a person who's vulnerable or medically at risk, and so would be prioritized, but they've had it? So those are two questions. Dr. Patterson?
I guess I thought the question was going to be a little different, and it was, after I get the vaccine, can I donate plasma? That's kind of an interesting question, right?
Well, take that on too.
So I hadn't thought about that. I guess part of the trial you shouldn't, but
the FDA just came out and said that you should not collect convalescent plasma from people who got immunized. So we've been all wondering that, and they came out and 2 days ago said no.
Probably not would be the answer from Dr. Matt. So when should you give plasma? You should become non-infectious. So different blood banks have different rules. And so you can still give plasma. Absolutely. It's a different question, but that's an important thing you can still do to help people.
And if you think you've had it, but you're still medically at risk, should you be among the first to get the vaccine? Should you want it, or should you wait?
I'm very positive on the vaccine. I know we've been, we've expressed a kind of a measured view tonight, I think. But these are really impressive results, right? They're only 2 months, but there are a lot of patients in the trials. And so I'm really hopeful this means a bright future ahead of us. Those are numbers that are great. There's some other questions in the chat about what about antibody responses and T-cell responses. Have tests been done on those and measured to show efficacy and what's been protective? And they haven't yet really, but I'll remind the audience that just a few weeks ago, Dr. Fauci and others were saying, let's be careful about these first vaccines, may not show that much efficacy. And a lot of it was based on the immunity that seemed to be developing. And so it may not correlate that well. If it, at least in the short run, it seems like these these responses have really been good and may not correlate that well with the antibodies or T-cell responses per se that we can easily measure right now. Maybe we're going to learn more in the future for sure.
There's a general principle that if you've gotten COVID, you're not going to contract it again for 3 months at least. The CDC recommends that you not retest people within the 3-month window, and you're considered to have protective antibodies. After that, we don't know. The studies are ongoing to try to figure out how long natural immunity lasts. We see that the kinetics of neutralizing antibodies change, and these things can fade. There are 4 other coronaviruses that circulate in the community. Most people, when you get one of those, you're immune for 1 or 2 years. And so we're looking to see, is that going to be what natural immunity is like for this one? We just don't know. The first cases were less than a year ago.
Next question in the chat, I'm going to direct to Dr. McCarthy. Do seasonal flu vaccines prevent transmission of disease?
So you can still be a carrier. This is, again, what we look at. I take care of people every year who got the flu vaccine and still get sick with it. So, what we are seeing that's fascinating. So yes, you can still transmit the virus. What we're seeing that's fascinating this year is that there was a worry about a twin pandemic of influenza and coronavirus. That doesn't appear to be happening. We are seeing some of the lowest influenza levels in recent memory. And this was actually something that was predicted a few months ago when we looked at South America and Australia. The circulating influenza levels were just very, very low. So this has been, in a year of bad news, one of the bright spots has been how little influenza we've been having to deal with. And the thought is that the mitigation strategies of wearing a mask and social distancing is affecting the transmission dynamics there. So a small bright point. And even though the levels are low, we still strongly recommend people get their flu shot.
Excellent, and a good opportunity to get your flu shot when you go see your provider to talk about the vaccine, or when you actually go to get the vaccine. I assume you can get vaccinated for both at the same time if you wanted.
Well, there's one study right now that's just launched in the United Kingdom. They're looking at a twin vaccine of coronavirus and influenza, corona and influenza vaccines together, but they're not going to be formulated in the United States together, at least in the near future. But we'll see.
No influenza vaccine in the near future for us. Yeah, patent pending on that one. Question from the chat is about when will the kids get the vaccine? There are millions of kids that need to go back to school. We need to think about the effect of getting vaccinated on not further disadvantaging poor communities who have children and need to go to school and thrive and get on their way and with upward mobility. So how are we going to prioritize children, and how are we going to get the herd immunity in those schools so that they can be there safely? Dr. Allison, any thoughts on how we can prioritize children and maybe even strategize how to get kids back to school?
So I think the first step in vaccinating kids is having a vaccine available, and we just don't have data yet about vaccination, COVID-19 vaccination in kids. When we do have one, I think the question is going to come up with a lot of parents around mandatory vaccination, right, for schools, because that happens with a lot of other vaccines. And the challenge with doing that with this vaccine, again, is going to be around the fact that it is technically going to, well, it depends when it actually depends when we get the pediatric formulation, but it is still likely to be semi experimental at that time, and there isn't this longevity of data collection to mandate it, for example, for entry to schools. And so I think in it, at least in the initial phase when it becomes available, I believe that it's going to be choice, and the choice is not the child's, right? The choice is the parents. And so I think, again, we are going to have to provide good information for parents, because they want to know that what they're giving to their child is safe. And so that kind of communication is going to be important.
I'm looking at the time, and I really wish that I wasn't seeing 8:27, because I'd like to sit here and speak with this panel for at least another hour. But I want to land on this question of mandating a vaccine. And I'm going to let Jason Morrow tackle this question, because we've been talking about it in our vaccine committee locally. And I also want to then let Jason hang on to the microphone and wrap things up for us here in the last couple minutes.
Well, thanks for dropping a difficult question on me. Mandating a vaccine, it sounds so attractive, right? It's so important to our public health that we have this herd immunity, that we have enough people successfully immunized that the virus can't travel among us so easily. That's how we get to the end of this thing, right? Is if we can all get immunized, and if we can all live through it, right? We don't want to get, as Dr. Patterson said, we don't want to get immunized and take a risk from the actual virus. We want to get immunized from a safe vaccine, and we want to get there from here. So mandating sounds attractive, but I really think about what Dr. Allison says about trust and storytelling and messaging. In America, mandates don't go so well. We like our freedom. And in truth, the way to respect people is to engage them, is to educate them, reach out to them, and act from a position of compassion. And if we can help people through health literacy campaigns, through education, and just earning their trust to have higher uptake of a vaccine, and we can continue over time to do a good job with messaging and transparency and a sense of accountability, so that we can learn as we go and show that over time that this is safe and approximate the traditional studies that are done on vaccines before they are actually offered to people, then I think that's how we get there from here. When you think about mandates, you're usually thinking about mandates in the workplace. My workplace requires that I get the influenza vaccine. It requires that I get other types of vaccines. Kids need to get vaccines to go to school. So it's usually within a controlled setting that mandates are offered. Certainly with the coronavirus and COVID vaccines, you cannot mandate something that's authorized but not approved. So that's an easy question for now. If it's authorized but not approved and not subject to the traditional safety evaluation, then we're just going to have to wait. And then I think we can continue to evaluate whether we need to mandate it by the time it becomes approved, depending on where our herd is gathered. And just another thought about where we are in this moment and the ethical principles that should guide us. It's a really tough moment. It's a really tough moment because 2020, if anything, has exposed the fissures in our community, the us versus them, and those fissures run deep. The quakes of power that gave rise to those cracks are deep and long and really buried deep within our country's history. In 2020, we see racial divides as deep as we've seen before. We see disparities in education, in health, and in just wealth in our country. And right now it feels like we're really divided. But as Dr. McCarthy said early on, there's something hopeful and positive afoot here, where we are bringing together our best, our brightest, that we are persevering through this tough year and finding ourselves here in December on the verge of some sort of collaborative effort where we're going to come together, and this herd is actually becoming worthy of the trust that we invest in those who have power and those who have authority. We want healthcare workers to get the vaccine first because we want a stable healthcare workforce that can care for people. And beyond that, we want everybody to get vaccinated, especially those who are vulnerable, who are marginalized, who are medically at risk, because they deserve to be protected. And if we failed them in the past, we can do right by them now.
Thank you so much, Jason, for your concluding comments. Again, my major regret is that we can't stay here for a long time and work our way through all of these questions. We are going to try to capture as many of these questions as we can from the chat. We also have the opportunity to interact with our audience electronically via email going forward. And so we do invite you, if you want to continue the dialogue electronically, to email with us. I'm reminded to let everybody know that our partners in Metro Health in San Antonio have a message. And Metro Health is very interested in understanding your perspectives as a community about which groups should receive the COVID vaccine first. What is right for San Antonio? Dr. Allison educated us that there's no one size fits all, that there are microenvironments within any community. So there will be a variety of different approaches to answering this question. But your input, along with data about who is most disproportionately affected, will help our Metro Health with San Antonio's vaccine distribution planning. So please share your input on the Metro Health survey. The link to it is listed here at www.surveymonkey.com/r/CV19 vaccine. And there is a QR code. We will leave that slide up for a bit so that people have a chance to access that information. And for more information on COVID-19 vaccines, you may visit the cdc.gov website listed here on coronavirus and vaccines. So with that, our session is ended. I want to thank each and every one of our panelists. Dr. McCarthy, I think you're going to become an honorary San Antonian. We might need to give you a key to the city if you show up again. And we can't wait until everybody's vaccinated and travel is possible so that we can take you out for some good Mexican food. Dr. Allison, Dr. Patterson, Dr. Morrow, thanks to each of you for the thought that you put into your preparation for tonight and the care with which you delivered your answers. Our session is now concluded, and I wish you all a good night and a safe and healthy Thanksgiving. Thank you.